illustrative. All right, the first one's a 6-year-old kid, one day of abdominal pain, started as a tummy ache, mom didn't think much about it, and then it kind of migrated and localized to the right lower quadrant. He's thrown up once, at home he had a temp of 38.3, let's say mom's British and she measures everything in Celsius. Hasn't had any diarrhea, doesn't hurt to pee, and he's got rebound tenderness. All right, the bumps hurt on the way in. In the ED, he looks uncomfortable. All right, and his fever's gone up a little bit. He's not particularly tachycardic or tachypnic, all right, so you're not thinking that this is all being driven by chest pathology. And when you examine him, he's focally tendon in the right lower quadrant with mild distension. You do some lab testing for that white count, all right, the ever important 14.2, his ANC's up and his UA is negative, all right. So with that history, those lab tests, that exam, I would consider that to be a slam dunk, right? That's what we all hope to have. Classic presentation, classic lab testing for acute appendicitis. You know, that's a kid at our institution where we pick up the phone, call the surgeons, and that child will likely go off to the operating room with nothing more. Contrast that with the more common presentation. All right, a 9-year-old girl, 2 days of lower abdominal pain, hasn't really had much of an appetite. She hasn't been febrile, no vomiting, no diarrhea. She's premenstrual. Afebrile, and when you examine her, she hurts everywhere. She's one of those kids, yeah, it hurts there, yeah, it hurts there, and there, and there, and there. All right. Her white count is a little lower, it's 11. Her UA, maybe a little dirty. 3 white cells per high power field. And so, you know, with that history and that exam, you do further testing, all right, and you get an ultrasound. The ultrasound is performed and is unremarkable, but the radiologist comments that the appendix could not be definitively visualized, all right? And so now what we're left with, it feels like you know, what I would do is I would run into the waves and try to drown myself. You know, this is painful because the possibilities are limitless here, right? And the question is, okay, now where do I go? So we'll come back to this at the end as well. So this is our work in progress kind of pediatric appendicitis workup grid. All right, and you're going to see some things up there that may be unfamiliar to you, like PAS, Pediatric Appendicitis Score. But what I'll hope to show you is that being diligent about this, incorporating clinical scoring schema into your evaluation of abdominal pain can hopefully decrease CT utilization and make your workup more accurate. All right, and so this is what we've settled on. All right. And we'll come back to that. So our job is all about playing the odds, assessing risk. So you ask yourself, all right, what is the risk, all comers, pediatric patients presenting to an ED with abdominal pain? All right, what is their risk of appendicitis? Turns out if you take that large group, 1 in 10 will have appendicitis. So all comers presenting to an ED, the risk is 10%, so walking in the door. All right, contrast that with those who come from somewhere else, whether it be their pediatrician's office, another hospital, for rule out appendicitis. That was one of the most common chief complaints when I was a pediatric emergency fellow at Children's, was sent in to rule out appendicitis. Well, it's interesting that the number is actually quite higher for those patients, so your risk goes up. So 1 in 4, 25%, if they've been referred in rule out appendicitis, will ultimately be diagnosed with that disease. All right, so that's the number to have in your head as you're evaluating pediatric patients in your ED. The goal here is not to be struck by lightning, all right, and miss this diagnosis. Somewhere underneath there is a pediatric emergency physician that's lit up hair on fire because they missed pediatric appendicitis. It still is an important medical legal diagnosis. It's the #2 cause of medical malpractice for peds emergency physicians is missed appendicitis. #1 is missed meningitis. And there's a time component here. All right, depending on the study you look at, perforation becomes much more common the longer these children have symptoms. all right? And so you've got to be careful, and often we use the emergency department as that captured moment, all right, to work up and diagnose these kids, all right? Because we got about 36 hours before the rate of perforation goes up dramatically. And this is something that I still see very, very ill children with, all right? Kids still die from this appendicitis. You would think that 2018 that wouldn't happen, but it absolutely does. So let's talk about epidemiology, because I think there are some important takeaway points here, all right? The numbers that you see. So the incidence is 1 to 2 per 10,000 in kids 0 to 4. That incidence goes up tenfold, all right, once you hit 4. So basically kindergarten. So what that tells me, all right, is that below the age of 4, it is a relatively rare disease. All right, so you got to think about it, but you also don't want to take every 3-year-old with a tummy ache and focus on appendicitis to the exclusion of other things, whether that be the patient who really does have intussusception, a neonate, all right, it's going to be an incredibly unlikely diagnosis there. If they're sick with an abdominal cause, thinking of things like malrotation with midgut globules, right? Those things occur at a higher incidence when you're a younger child, right? Once you hit school age, then that's the age where we start to see this diagnosis more commonly. Because it's rare in the young children, almost all of them will be perforated at the time of diagnosis. All right, and that's why that occurs is multifactorial, right? The younger you are, the harder you are to evaluate. You may be pre-verbal, right? The symptoms of appendicitis overlap significantly with other more common diagnoses like infectious gastroenteritis, all right? And so these younger children will present later in their disease once they're ultimately diagnosed. So how do we go about this? So history, all right? It's still going to come down to history, physical exam, and then confirmatory lab and radiographic studies, all right? When you take a look at this, so classically speaking, vomiting is present and it occurs before the onset of pain. If you're not vomiting, all right, that actually has been shown to be protective and lowers your risk of appendicitis. All right, you shouldn't be hungry, classically. You should have a fever, all right, though that is remarkably variable in the literature. All right, and one thing I will tell you is diarrhea can happen with appendicitis, especially in young children, that group that we don't do well with. All right, so, you know, the resident that comes out and says, oh, I got a 3-year-old who's vomiting, febrile, and has diarrhea. They got gastro, they can't have appendicitis. It's actually not true, all right, and you've got to be careful with those kids. The physical exam, all right, we push on a bunch of bellies. That's the best way to go about this, all right? If they're febrile, that increases the likelihood, all right? Migration of pain is actually a stronger predictor of appendicitis, all right, than focal right lower quadrant pain. And not surprisingly, if they present with peritonitis, all right, that is highly predictive of appendicitis, and in those cases, likely perforated appendicitis. The problem with all of these classic things is it's a flip of the coin. They don't occur commonly, all right? So half the kids don't migrate, all right? The pain may stay periumbilical the whole way, or it may start in the right lower quadrant and stay there. One of my favorite things is, you know, junior surgical residents will come and say, well, it can't be appendicitis because they want to have a piece of pizza, right? They're not anorectic, so that can't be. Well, 40% of the time that doesn't occur, all right? And then obviously, hopefully, most of the cases that we diagnose are early enough where we're not seeing peritonitis. Lab testing can help, all right? I get into this fight a lot with our faculty. This is actually one of the biggest bones of contention amongst our faculty when we discussed this pathway was the utility of a white count. Surgeons love it, right? I cannot call a surgeon without that piece of data at the tip of my tongue. Emergency physicians love to say, well, you know, I've seen appendicitis with normal white counts, and that's absolutely true. all right? But there still is a lot of data out there that shows that an elevated white count increases the likelihood of acute appendicitis, all right? As does a left shift, so an ANC that's elevated. We're going to come back to this when we talk about scoring, but this guy here, Anupam Kharbanda, he's a great guy. He and I were fellows together. I would consider him to be the nation's expert on pediatric appendicitis in the ED. He found that a low ANC is actually remarkably protective. All right, so you can use these lab tests to kind of, in your mind, shift risk around and decide, kind of what bucket to put these kids in when you're seeing them. I had never sent a CRP in the workup of appendicitis until 18 months ago. One of our pediatric surgeons from Montreal, where he trained, brought this practice with him when he came to Maine Medical Center. And it was one of those things I'm like, why am I sending this non-specific inflammatory test to help me out here? But when you actually look at the literature, there's good data for it, all right? It's interesting in that risk-wise, white count outperforms CRP in the first 24 hours of illness, but then CRP is a more powerful predictor of who has appendicitis or not from 24 hours on, all right? If it's normal, it doesn't really help you, meaning if a normal CRP does not exclude the diagnosis, all right, but an elevated one can be helpful as you're risk stratifying. So a lot of yeah, can help, no, maybe not always, classic, non-classic presentations. This is rife for a clinical scoring schema, all right? It really is. Putting all of these disparate data points from the history of the physical, lab testing, and ultimately radiology together to try to help us at the bedside have these discussions with parents and image appropriately, but not over image. And it really comes down to risk. All right, there are high-risk kids, there are low-risk kids, and then there's that gray area in between. Okay, I'm going to only speak about validated pediatric clinical scoring schema. All right, and I think that's important because there are numerous scoring schema out there for appendicitis, not all of which have been studied with the same rigor in children. So again, we're back to Anupam Kharbanda. This is the Kharbanda low-risk appendicitis score. All right, it was derived and then validated in a pediatric population. It is one thing that you can use, all right, to have that discussion with parents if they don't have an elevated ANC, if they're not maximally tender in the right lower quadrant, or if they are, they can jump, all right, and walk without pain. All right, they are at exceedingly low risk, much less than 1% will ultimately be diagnosed with appendicitis. So if you satisfy these criteria, these are children that, quite honestly, don't need anything further, okay? Now, that doesn't skim a lot of patients off here, right? A lot of kids, when they jump, will say, yes, it still hurts. All right, but if you can get them to do this, you have a validated clinical score that says, I don't need to go any further. I don't need an ultrasound, I don't need a surgical consult, and I certainly don't need a CT. All right, I can safely tell the parents, this is unlikely to be appendicitis, give them good, appropriate discharge instructions if things change, and let them go home from the ED. The other validated score in children, pediatric appendicitis score. It's a little bit more complex, but it is nowhere near what your NIH stroke scale is, your Yale observation score. It's a 10-point score. I have a dot phrase in Epic that pulls this up for me, all right? And it takes historical features, physical exam features, and some lab data and gives you a 1 to 10 score. And this is how that performs. So if you have a low pediatric appendicitis score, all right, 0, 1, or 2, they have an exceedingly low risk of ultimately being diagnosed with the disease. These are children where you can safely say, we can stop here, all right? If things change in the next 12 hours, you need to be reevaluated. Go home, we don't need to do anything further, all right? And the way I kind of phrase this to parents is we're trying to put you in a bucket, right? We've got a low risk bucket, we've got a high risk bucket. high risk bucket, you're going to meet one of our surgeons, all right? Low risk bucket, it's okay to go home. And that medium risk bucket is the test zone, the imaging zone, all right, where we're going to need some more data. I would advise you not to use the Alvarado score in children, all right? We use that in adults. It's validated there. Compared to the pediatric appendicitis score, the Alvarado score is worse, all right? It really exaggerates the risk at the high end, all right? So I'm calling a surgeon and saying I've got, you know, high Alvarado score, need to go to the OR, and they go to the OR and they have a white appy, all right? So a negative appendectomy. And the low risk is still worse, all right, performs worse than the low risk pediatric appendicitis score, all right? So Carvana score to rule people out, pediatric appendicitis score to get them into those 3 buckets. Those are the ones that I would use. I will say that, as with everything, right, PCARN, great clinical decision rule. We use it virtually every single day, all right, to risk stratify kids and to decrease our head CT use, all right? Having a clinical decision rule, all right, to help you, it's so much quicker and easier to open the order set, click, you know, all, and sign, and order a bunch of tests than it is to take your clinical decision rule and then have that discussion with the parents. It takes time. You've got to sit down and make them understand why you are not doing anything further if they fall into that low risk bucket. There's nothing worse than, you know, we have people that will walk in and say, you know, doesn't have appendicitis, you can go home with no further explanation, all right? So utilizing these powerful clinical decision rules, all right, does not obviate your requirement to sit down at the bedside and talk with patients about why they're in the low risk or medium risk or even high risk groups. When we get, how many of you in your ED practice or your practice right now can get an ultrasound of a pediatric patient to evaluate for appendicitis? How many of you cannot at your current location? It's about 30%. Okay. I would say over the last 10 years, slowly moving that way, ultrasound has taken a more prominent role because of its lack of radiation. I would say that it is approaching standard of care at this point. For those of you that don't have access to this, I would start the discussion, all right? I would start the discussion because parents are starting to care about this. They're hearing the lay press about radiation risk, and if all you have is CT imaging to offer them, you know, you will find some parents who are savvy enough, they've been on Google, and they know about the radiation risk with CT, and that may be concerning to them. You know, ultrasound's great. It is highly operator dependent. The numbers quoted in the literature for sensitivity and specificity are anywhere from the 70% to as high as 90%. I will tell you in my own anecdotal clinical practice at Maine Medical Center, we don't have those types of rates, all right? It is not uncommon for us to send somebody off to ultrasound and to come back and get a non-diagnostic. Can't see the appendix. Nothing that looks bad, but I cannot definitively exclude the diagnosis, all right? But it's worth a try. It's worth a try because there's very little downside to it from an individual patient standpoint beyond cost. And interestingly, when you read the American College of Radiology, their imaging recommendations, they're choosing wisely, so to speak. They strongly recommend ultrasound prior to CT for this diagnosis. So what constitutes a positive ultrasound? Well, you see appendicitis, right? You see a swollen, non-compressible structure in the right location with a thick wall, right? And typically there's going to be pain with compression. The presence of a calcified appendicolith can also be helpful in the ultrasound diagnosis of this disease. And then there are some secondary signs, all right? So we see this from time to time where they cannot definitively identify the appendix, but they see thickened echogenic fat, or they see free fluid in the right lower quadrant. If you don't see any of those secondary findings, even if you haven't identified the appendix, all right, your risk of appendicitis as your ultimate diagnosis is below 2%. All right, so even in those cases where you're not definitive, all right, depending on the individual patient that you're dealing with, how far along in their course they are, the reliability of the parents, all right, even if you haven't said 100%, I see the appendix and it is normal, if they don't have any secondary findings, they're at relatively low risk. So I think a reasonable clinician in those cases could say, you know what, we're gonna let you go home. See how the next 8 to 12 hours go. If we're getting better, great. It was probably something else. Stomach flu, mesenteric adenitis, you know, whatever. All right, but if things are progressing, come on back and we'll try again. And finally, CT, right? The end terminus of all ED workups occurs in the donut of truth. CT utilization is up across the board. We're doing a better job in pediatric patients than we are in adults at kind of trying to limit this where appropriate. But it's interesting, all of the papers out there that have looked at CT imaging, and there's been some good ones, including one published in JAMA now 12, 15 years ago, have not shown that increased CT utilization decreases negative appendectomy rate. And you know, what I would advocate for you guys is to adopt a clinical scoring schema. For me, it helps to put things into perspective and to give some kind of rigid guardrails for me as I'm talking with patients and parents. It also very much helps our trainees kind of navigate some of these waters, which can be murky. All right, but don't forget that those of you out there that have been doing this a long time, that your clinical gestalt, even if it is with kids who you may not be as comfortable with as your adult patient population, your clinical gestalt is actually pretty darn good. All right, when they've looked at this, you know, kind of a standardized workup versus clinician gestalt had a likelihood ratio of 5.8. So those that the doctor said, I think this is appendicitis, they were right a lot, okay? And so it's not to say the clinical scoring obviates being, you know, a good, careful physician, because that's still quite valuable. So we're back to here. All right, you can see a couple things now that we've kind of gone through some of this data. Number one, you can see that for us, low risk is a pediatric appendicitis score of less than 4, not less than 2. All right, so we've kind of upped the upper limit of the low risk, but we've also in our clinical pathway said to be low risk, you've got to have a normal white count and a normal CRP. And that's quite honestly a nod to our surgeons. The surgeons, you know, the way they train, they put a lot of import on white counts and in this condition, CRPs. All right, and so we're not following the letter of the law on the pediatric appendicitis score the way it was developed, but we feel that this works for both of our groups. And for us, this has to be done in collaboration, all right? Because you can see, if we're in the high risk for appendicitis group, we're calling our surgeons. If we're in the medium risk, all right, we're getting an ultrasound and calling our surgeons, all right, especially if it's non-diagnostic. So, you know, they're committed to this. They're working with their group, all right, because this has increased the number of times we've seen the pediatric surgical service in our ED, all right, because a lot of these non-diagnostic ultrasounds, we were kind of in the past left to kind of make it up as we went along. Some we'd send home, some we'd consult, some we'd go and get a CAT scan on. And so now they're partaking in the workup at an earlier point and more frequently. All right, and we've also seen a willingness to admit some of these gray zone patients. All right, so white count of 14,000, CRP that's up a bit, non-diagnostic ultrasound, rather than just pushing the button and going to CT. Our surgical colleagues are now much more willing to admit and observe. with serial exams, all right, on their service, not in RED, than they ever have been before. And that's been very, very helpful. And again, you talk about this, the goal is to not miss the diagnosis, but any intervention you put into place, I worry a bit, I don't want to cost the patient more, right? And so, an overnight stay in our hospital on observation status in the era of high deductible health plans may kind of get close to what a CAT scan would cost in dollars, all right? Again, what you're saving there is the radiation that comes with a CT scan. So take home for me is this continues to be a challenging diagnosis, particularly in the very young infant, right? We miss this a lot. Almost all those perfed kids that we see in that 0 to 4 age range, you look back in their chart and they will have had contact with a healthcare provider at some point during the earlier part of that illness. And so it's keeping this on your radar, being diligent and careful in your history and physical, appropriately ordering labs, all right, and using radiology, all right, to help you kind of figure out that middle group. A lot of you may work in institutions where you don't have a pediatric surgeon. I get that. We're actually at our health system level, all right, our main health system level, talking about how we might roll this out system-wide, all right? So those kids that show up at Miles Memorial Hospital in Damerscott, Maine, they don't have a pediatric surgeon to insert into this box here. So what would it mean if they got down here, all right, and they got an elevated white count, they got a non-diagnostic ultrasound, send them to us at Maine Medical Center, all right, transfer them without a clear diagnosis, telehealth, all right, pop into the room, the ED doc does the exam and shows what they're seeing, all right, all of those things are on the table, but our pediatric surgeons are committed system-wide, because they are our system-wide surgeons, to decreasing this rate. And so we're going to try to get fairly creative with this across the health system to try to reduce that NSQIP number of 40% pre-op CT. All right, so that may be coming down the pike for you all if you practice in rural Vermont, for instance. All right, I'm going to stop there and take questions. Sir?
I'm seeing recommendations for MRI in the pediatric population.
Yeah, so the question was, he's seeing recommendations for MRI for pediatric appendicitis, and that's absolutely being done in certain centers. All right, again, MRI can get you to the diagnosis. It's a CT scan without radiation. For us, we are not currently doing that, and MRI is as rare a resource in many places as a pediatric surgeon. And often, unlike CT scan where it's not as claustrophobic, you're in and out in 3 minutes, an MRI takes longer, and many pediatric patients will require some degree of sedation to get through it. The young ones, even general anesthesia to get through it. So you're absolutely right. It'll get you to the diagnosis. I think in pediatric patients, there are some things that enter into the equation with regards to getting that test done and the availability of said test in certain circumstances to make that. I would be shocked if that, 15 years from now, we're doing MRIs on all these, all right?
And there seems to be some evolution about the radiologist preferences for oral and IV contrast.
Yeah, so the study I mentioned 10, 15 years ago in JAMA, so basically nowadays, if you are going to do a CT scan, you absolutely can just do that CT scan with IV contrast, all right? They do not need oral contrast, all right? We even studied rectal contrast, which for me, holy smokes, I would not want rectal contrast. But the rectal contrast worked. It was very uncomfortable, and when they studied it head-to-head, IV, PO, or rectal, IV is as good, if not better. So your CT scans, if you end up there, all right, can be done with IV only. Mark?
Nate, do you factor timing? Because you had that data about them not perfing or perfing more after 36 hours, and then Bacher had that study where the ultrasound was more likely to be positive the further you got into the diagnosis. So.
Yeah, so I think the question is about duration of symptoms and how that plays into things. It does in the sense that I am much more likely to let somebody go home who scores low on the pediatric appendicitis score without any imaging whatsoever in the early part of their illness. So if we're talking 36, 48 hours, I am much more careful with those children and much more likely to engage pediatric surgery, especially if they've got an elevated white count or CRP, because we know that those start to perform better the longer you get out, and I have a lower threshold to image because their risk of perforation is higher. So I do make different imaging and disposition decisions early on versus late on. The reality of it is that modern day pediatric medicine, people wait about an hour and a half with any specific symptom before they come to the ED. Right? The era of feeling an olive in pyloric stenosis, right? Seeing the peristaltic wave, right? Letting your child be at home, for 2, 3, 4 hours, 10 hours, 12 hours, 24 hours is becoming more rare. They get a symptom and they are seeing a healthcare provider. I'm seeing an earlier presentation, which can be, on the one hand, problematic, all right, because many diseases become more clinically evident as time goes on. But in many cases, it also gives us a little bit of a margin of error, right? You've got a kid with focal right lower quadrant tenderness of 2 hours duration. They've got a fever, and you do an ultrasound that is non-diagnostic, all right? There, you can make different decisions if they're 4 hours into their symptoms, all right? You can safely say, all right, before we CAT scan you, I think it's okay for you to go home, all right, because their risk of perforation is lower than somebody presenting on the tail end of that at 36 hours.
On the flip, though, if you're at, say they come in at 48 hours or 50 hours, whatever, and the ultrasound's non-diagnostic, does that reassure you more because of that study from Boston Children's, or not so much? Not
so much, and it comes down to how good your ultrasound people are at seeing this diagnosis. And again, I would hazard that our sensitivity for this diagnosis at Maine Medical Center is much more around the 50-50 mark. Pete, do you have thoughts on that?
Yeah, it is so tech dependent. I mean, as you're seeing more and more ultrasound techs, they are getting better across the board. The demand is getting higher for this thing. But boy, just from working in the community, working at Boston and Maine, the variety of skill levels is just startling. So, yeah, not a lot to add.
Yeah, so if they have a completely non-diagnostic exam at 36 hours, I'm more likely to recommend observation, in-house observation. Any other questions? Comments? Abby?
I don't know the literature that well, but there was some literature about treating appendicitis with antibiotics instead of surgery. I don't even know if that was pediatric, but do you ever, if it's equivocal, work up, admit ops, and give them antibiotics just to play it safe?
We have not embraced non-operative management of appendicitis in children at our hospital. There is data out there. The strongest data is in adults. We actually had a journal club on this probably within the last year. It's interesting. The non-operative proponents will show you literature that suggests that the incidence of C. diff is actually higher if you're status post-appendectomy. It's thought to be the place where normal gut flora is stored, so that if you get an illness, a GI illness that kind of wipes out your normal gut flora, the body can go to the appendix to reconstitute that. And so they'll point to that as one of the markers or one of the benefits of non-operative management. When you look at it, our pediatric surgeons, they'll take non-perfed appendicitis to the OR and literally discharge them from the PACU. They don't even stay overnight in many cases. And so risk-benefit wise, especially in a pediatric population, a not insignificant number of those in those studies that were treated with IV antibiotics rather than surgery had complicated courses and costly complicated courses. You know, long-term antibiotics, the need for a PICC line, right? A 5-year-old, it's going to be difficult to manage, all right? Most of these were done with IV antibiotics rather than PO, and maintaining an IV in a child in and of itself can be a battle. And so for all of those reasons, we have not gone that route. I think that getting your appendix out in 2018 is a fairly safe procedure in all cases. So, all right, we're done.
I'm so sorry you guys have to suffer me twice today. But sometimes like ripping off a band-aid, just get it over with once. This talk is a little unrelated to the first one I did earlier. And this talk is about sudden sniffing death syndrome. Has anybody ever heard of sudden sniffing death syndrome? Maybe 5, 6. Okay. Has anybody seen it? 2, 3. Okay, perfect. For those of you who have not raised their hands, this is an incredibly important thing for you to know, because when you see a patient with this, you will not have time to look up anything. Okay? But before we get started, I have to kind of keep up with the times, because in the most recent weeks, the Tide Pod Challenge has become a thing. You guys heard of the Tide Pod Challenge? Anybody tried it? Okay, good, just making sure. So the latest craze is after the saltine challenge and the cinnamon challenge and the nutmeg challenge. Now you take a Tide Pod and put it in your mouth and bite on it. And kids put videos up on YouTube, which YouTube is trying to take down in real time, of them doing it. I don't know why they're doing it, but I've stopped asking questions as well. The problem with Tide Pods that is a little different than cinnamon and saltines is that Tide Pods are highly caustic. So I just want to run through this so that if you see a kid with this, you kind of have a framework in your mind, and then we'll get back to the real lecture. So they're really caustic. They contain 13% propylene glycol, which gets metabolized in the body to lactate. So you can develop a pretty significant hyperlactogenic acidosis from eating them. The real problem, however, is the alcohol ethoxylates that are in the Tide Pods. That they have surfactant properties, but they're really crappy surfactants. Because this very often causes vomiting, it also very often causes aspiration. And just a minute amount of aspiration of alcohol ethoxylate into your lung will cause global alveolar collapse. And these kids can develop respiratory distress as early as right away, and as the latest 2 to 3 days. Because of the causticity and this causing liquefactive necrosis, you can get severe esophageal injuries from Tide Pods. Unfortunately, things that you see in the mouth don't necessarily predict the things that you'll find in the esophagus, and we know that from the exploratory ingestions before this craze began. If you have a grade 2B or greater esophageal injury from this, you have a 70% esophageal stricture risk, and your lifetime esophageal cancer risk increases 3,000 times. That's 30,000%. So the kids that do have a grade 2B injury, they will need lifetime surveillance endoscopies to screen for cancers. Therefore, if you have a kid that was stupid enough to do this, and they have any lesions in their mouth, they have any pain when they're swallowing, pull the trigger and scope it. Okay? And that's just a quick Tide Pod Challenge update. But what I really want to talk about today is the sudden sniffing death syndrome. So let me tell you the story how this very often presents. There is a store employee that's walking down the keyboard aisle in the office supply store where the keyboard duster is kept, and notices that there's a kid just directly inhaling from a can. And when the kid is discovered, the kid just falls over and is dead. And first, the employee thinks it may be faking, poke them, they're non-responsive. So an ambulance is called, the medics arrive, and they found that this kid is in refib. So they start running a code, they bring it to the hospital, and you receive them at the hospital, and this is a 12, 13-year-old kid. Parents are coming in, the nursing staff is nervous because coding kids sucks. You are nervous because coding kid really sucks. And you can't get them out of refit. You give them amio, you shock them, you give them mag and calcium and IV fluids and bicarb, and just nothing works. You just cannot get them out of atrial fibrillation. And you following your ACLS algorithm, and after 2 hours, you call it quits. Right? So this is unfortunately the typical presentation of a sudden sniffing death syndrome person. Apart from the story that you get from medics, the only hint you'll get on physical exam, maybe a little bit of frost burn around the mouth, but that's only in compressed volatile inhalants. It's not universal for sudden sniffing. So the example I gave you, somebody sniffed keyboard duster, which contains a chemical called 1,1-difluoroethane, and this is the chemical that gets you high, and it's also the chemical that kills you. So why do kids do this? And when do they start? They start as early as 5 years of age, when they start sniffing Sharpie, sniffing glue, and around 14 years of age, this really peaks. This is a teenager disease. And then something interesting happens when people hit their 20s. Either they stop and they grow out of it, or they transition to other drugs. But this is relatively rare in adults. We at UVM have one lady that comes in, that does this all the time, who carries keyboard duster in her bra so she can dust in the bathroom in the ED. But mostly this is kids. If you survey high school students, seniors in high school, 11% have tried a volatile inhalant to get high during their lifetime. 11%. And 5% have used it in the last year. So this is pretty common. If you go into some rural populations, lifetime prevalence can be as high as 48%. So why don't kids just smoke pot, like maybe you and I did when we were younger? For a couple of reasons. A, all these volatile inhalants, they're dirt cheap, and they're easy and legal to buy. So if you are a kid and you have just a little bit of pocket money, do you really want to spend $200 on cocaine for the weekend, or do you just want to buy a couple of bottles of keyboard duster? They're super easy to conceal, and if you get caught with it, they're not illegal to have. They don't show up on any drug tests, and the drug effect is very rapid, and it's short-lived, so that you can use this between classes. Right? You in geography, and you walk to math, you get high on the way over, and you're fine by the time you get there. So what do kids use? They're all aliphatic compounds, meaning they're mostly carbon-based. Propane and butane are very, very common. You can just get those at any kind of outdoor place. It's just camp stove fuel. Toluene is the solvent in super glue and contact cement that can get you high. Acetone from nail polish remover you can use. And then in the case of using keyboard duster, that's haloalkanes, so any kind of carbon that has halogens attached to it. But kids also use nitrous oxide, which is called doing whippets because it is the propellant that's used in Ready-Whip. And you can buy the cartridges with nitrous oxide if you have a home kind of whipped cream pressure dispenser. I don't know what they call them, sorry. But you can just buy the cartridges and get high of those. And then poppers is something that's not as commonly used. Poppers is amyl nitrite, which is in your old cyanide antidote kits. So if you open them now because you found something that has cyanide toxicity, they may be gone because somebody else used them. Last but not least, sniffing pain thinner has its own dangers because methylene chloride, while it gets you high, also gets metabolized to carbon monoxide in the liver. We're going to focus mostly on the haloalkanes in this talk. The way kids use this, it comes in very different flavors. If you just take a bottle of glue, for example, and you sniff from it directly, it's called well-appropriately sniffing. But this is kind of the rookie stage of this behavior. If you're a little more advanced, you soak a rag in it, and you inhale through the rag, and that's called huffing. If you want to create an atmosphere that you can inhale the highest concentrated forms of the chemical of your choice in, you put it in a plastic bag, and then you inhale directly from the plastic bag, which is called bagging. There's dusting, which is specific to keyboard duster. We spray the keyboard duster chemical directly into your areas, nose or mouth. There's various other things. There's, as I mentioned, whippets. There's glading, where you use the glade plug-in inhalers on the wall and inhale directly from them. So there's a variety of things out there. So how does this get you high? Because we need to understand, kind of on a molecular basis, how this works, so we can understand the toxicity that ensues. The simplest explanation is kind of the receptor hypothesis, although I must say I'm not buying into this. The receptor hypothesis is that, well, whatever you're inhaling binds to the GABA-A receptor and opens it, similar to benzos or alcohol. And we know that volatile anesthetics, isoflurane and sevoflurane, which are haloalkanes, bind to GABA. So we know this is happening for some, but I don't know if it's happening for all, because the chemicals are so diverse, it would be unusual that they all have the same property of binding to the same site on the same receptor. If it's not the GABA-A receptor, it might be antagonism at the NMDA receptor, which also has a dissociative effect, which we are familiar with when we give ketamine. That's the receptor hypothesis. It does not really explain the toxicity. The other hypothesis of how this works is the lipid bilayer hypothesis. So all your cells have this bilayer of lipids on the outside, and if you have a lipid-soluble substance, it will incorporate itself into the lipid bilayer. And most of the chemicals that are volatile inhalants are lipid-soluble. So the idea was, well, if we insert a foreign molecule into this highly organized structure, we disrupt the structure, we reduce the van der Waals interactions between the molecules, and we increase the fluidity of the membrane. And that would then result in the lipid rafts, where all your cell signaling machinery sits together in an organized fashion, of drifting apart. You reduce cell signaling, and you get high from it. But you can actually calculate out how much fluidity of your cell membrane would increase for a given amount of drug that you inhale. And it turns out that the typical therapeutic dose of these drugs would increase fluidity by about the same amount as an increase in body temperature of 1 degree Celsius. Now, you can become altered when you're febrile, and this may be the underlying mechanism for that. However, we don't all get high just because we warm up by 1 degree, right? So this hypothesis was refined a little more, and it is believed that the molecules preferentially insert themselves on the external part of the bilayer, because there's more on the outside than the inside. As more insert on the outside than the inside, there's now strain that's being developed in the lipid bilayer. And you have now lateral forces that are pushing against the molecules that are embedded in the membrane, visualized right here. And this becomes important when you're an ion channel. If you're an ion channel and you're closed, you have a relatively small diameter. But when you're an ion channel that's trying to open, you need to increase your diameter in order to allow ions to travel through. If you have incorporated into your outer lipid membrane several volatile inhalants, you now have increased lateral force against the ion channel, and it may be more difficult to open. This becomes very important when we talk about the pathophysiology behind the arrest. The problem with this kind of toxicity is that this is not a kind of chronically acquired toxicity, for example, with cocaine, where we know that you have atherosclerosis and you have scouring of the myocardium. About 1 of 5 people that die from this died on the very first trial. Okay? Very first time they were used it. And there's 3 ways you can die from this. The first is straight up asphyxia. Every time you inhale something that's not air, you decrease your FiO2 that you inhale, and that can make you a little bit hypoxic. But that in itself shouldn't do much, because the moment you become unconscious from it, the drug administration stops. The rag goes from your mouth. You're no longer pushing down on the button on the keyboard inhalant. Unless, of course, you want to go all out, you put a bag over your head, and you inflate whatever you're inhaling directly into that bag, and then you pass out and no one takes the bag off. So that's one way to die from this. The Brady arrest is a different scenario. Every time you inhale a compressed gas, like a keyboard duster, upon expansion that gas will cool, and it will cool to freezing temperatures. So these kids that are dusting, that are injecting it directly into their mouth, that gas can then hit the vocal cords. And it does a couple of things. First is a protective reflex from the body, where your vocal cords go into laryngospasm and everything just goes shut. Okay? You can't breathe. But then you also get significant frost burn that leads to swelling and can obstruct your airway. And last but not least, it is such a strong vagal stimulus, and you know from intubating kids that they sometimes vagal down a little bit when you put a laryngoscope in. This can lead to brain arrest. This can lead to a systole just by vagal stimulation. But the kid that I told you about in that little case example, the presenting rhythm was V-flip. And the cases that are being reported of this sudden sniffing death syndrome is always in the same setting. People ran away from police and collapsed. They were discovered, they collapsed. They had a very frightening visual hallucination and they collapsed. It has something to do with fear. It turns out that the pathophysiology of that receptor opening now becomes very important, because these lateral forces holding the ion channels shut messes with the conduction potential of the heart. So I know this is probably a throwback to like medical school here, but this is the action potential in the myocardium. And you can see that you need a variety of potassium channels, sodium channels, calcium channels to make this work. And if you prevent them from opening and closing properly, you're going to mess with this. Okay? You're creating channelopathies. And now we've created the perfect storm. Now we have a channelopathy due to the lateral forces from the inserted haloalkanes. We have hypoxia because maybe somebody's a bagger, they just had reduced inhaled FiO2, or maybe they had a little bit of laryngospasm. And now they get discovered, and they have their own adrenaline surge that irritates the beta-2 receptors on the heart, and that is the perfect storm you need to develop V-tach. And down they go. So what do you do with these patients? The problem is that paramedics are protocol-driven. Okay? They have a clear-cut set of things that they need to do when they find somebody cardiac arrest. And believe me, when paramedics have a kid that they're coding, they're going to stick to that protocol one by one. They're not going to deviate one bit. By the time that kid makes it to your ED, they probably have 3 or 4 rounds of epi. Is the epi helpful? No, the epi is fuel on the fire in these people, right? And that can be challenging because now you need to not just convince yourself, but all the people you work with in the ED to actually withhold epinephrine from these patients. You need to try to reverse the hypoxia. You need to continue CPR. You can try to defibrillate. It's not going to do anything. But most importantly, you have to stop giving them epinephrine. In fact, you have to reverse the epinephrine that they already have. And I know this sounds crazy, but in sudden sniffing death syndrome, you need to push beta blockers. Now, you want to use a short-lived beta blocker. You want to use esmolol because it wears off quickly. And the loading dose is 500 micrograms per kilo, and you just run that over a minute, followed by 50 micrograms per kilo per minute as a drip. And you run that in as you're coding because you need to take away the beta-2 stimulation from, and the beta-1 stimulation from the adrenaline that they have intrinsically, as well as what was iatrogenically administered. And only once you do that can you get these people out of V-flip and V-tach. The moment you have ROS, you shut it off. It still has a couple minutes half-life left, and you don't want to have a beta blocker in someone who's just reattained spontaneous circulation because they may have significant myocardial snow. That's the beauty of esmolol. You turn it off and it's gone in a minute or two. And if they go back into V-flip or V-tach, you just turn it back on and continue to code. Fortunately, not everybody codes. Some people just get discovered, and their parents bring them in out of concern for the toxicity, maybe because they're just inhaled chemicals. So now the question is, what do you do with these people? They come to the ED, and you know they're at high risk of developing a cardiac dysrhythmia. You can't just send them home. So these people, you need to put in a very, very calm environment. A calm room, dark room, variable stimulation. Don't let the parents or police confront them, because what you're trying to do is you're trying to prevent intrinsic adrenaline secretion. Get an EKG at baseline to see if they have any evidence of channelopathies already. Do they have the widen QRS? Do they have the Blohm QTC? Maybe give them a whiff of benzos to make sure they stay calm, and then you're just going to sit on them. The longest out reported case of cardiac dysrhythmia after volatile inhalant abuse is 4 hours. So after approximately 4 hours, you should have breathed off and disengaged the things from the lipid membrane, and you can send them home. This is the beginning of a career in drug abuse. This is the time to intervene, so don't just send them home, but refer them to substance abuse specialists as you do so. And I have a red light up there, so I need to shut up. Any last questions? Yeah?
Would you recommend using
So, what do you recommend to be? The shortest living beta blocker that you have. Be it labetalol. I would stay away from Lopressor if you can. This is also something that you should try to set up before the kid comes in. When you get the radio call of a story that sounds like the son's living death syndrome, you should talk to your pharmacist at that time. You should talk to your nursing staff and get everybody in that state. We're not going to give epi, and by the way, yes, we're going to give beta blockers. So you don't have to have that conversation when that patient arrives.
Do you go back to defibrillation tests once you start?
Yes, you should continue to try to defibrillate, but without any beta blockade, it's probably not going to work. So once you have the epilogue work, at least. All right, well, thank you so much.